This episode of AHLA's Speaking of Health Law is sponsored by BDO. For more information, visit bdo.com.
Hello, I'm Julie Tatesman, a managing director in the Healthcare Forensics Group at BDO, and I recently retired from the United States Department of Health and Human Services, Office of Inspector General, where I was Chief Medical Officer. And I am here today with former Inspector General, the Honorable Christy Grimm. Christy.
Thank you, Julie. Yes, I am Christy Grimm, and I am also a managing director at BDO. And most recently, until January, I was the Inspector General for the United States Department of Health and Human Services, and I ran the OIG for a grand total of 5 years. And I want to thank everyone for joining us. Today, we are going to talk about artificial intelligence in healthcare and how it is already reshaping how care is delivered and how accountability works behind the scenes. In the first half of the conversation, Julie is going to walk us through how AI is showing up in clinical care and in the business of healthcare, from helping physicians manage information to transforming the revenue cycle process. And then we'll turn to the oversight side of the story, how technology, including artificial intelligence, is supporting government efforts to protect public funds, to detect risk, and to promote transparency. And to be clear, this isn't a world where algorithms are running audits on their own. Oversight is still in the early stages of adopting AI, but the groundwork is being laid through data analytics, through automation, and through risk modeling. Across both halves of the conversation, Julie and I are going to continue to come back to the same themes: how technology can improve performance, why human judgment still matters, and what good governance looks like in this new environment. And so with that, Dr. Tatesman, I turn it to you.
Thank you, Christy, and thank you to AHLA and to BDO for making this podcast happen. And it is such a timely moment for us to be doing a podcast on AI in healthcare. Christy and I are recording this in November of 2025. And just last month in the New England Journal of Medicine, the case records of the Massachusetts General Hospital had an AI chatbot be the guest diagnostician for the first time. Now, this is a special section of the New England Journal that was founded by Dr. Cabot over 100 years ago. And how it works is a physician is invited to assess a mystery case. And you know you've arrived in medicine when you're invited to participate in this special section. And in October of 2025, they invited Dr. Cabot, capital C-A, capital B-O-T, Cabot, to be the guest diagnostician. And not only did Dr. Cabot arrive at the correct diagnosis, but the reasoning that Dr. Cabot presented was so clear and so rationally organized to reach the diagnosis. It was truly a milestone. So, Christy, before we dive into AI in healthcare, let me just ask you, how do you use AI?
I use it more now than I did even as recently as last November. I use it as an assistant. Before the most recent updates to AI and things like Chat GPT-5, I was worried about accuracy issues, and I used it really for basic things like scheduling, to proofread something that I'd already written, to winnow options for a choice that I needed to make. But now, through testing and feeding and teaching, I'm using it in more comprehensive ways to collect, to analyze, to synthesize topic-specific information for me to review and to potentially use. And it's great. I've shared with people that it's like having a work partner. I still do a lot of checking to make sure the information is correct, though, and kept in the right context. But I use it daily throughout the day. Julie, how do you use AI?
I have to bifurcate that answer because I use it very differently in my personal life versus my professional life. In my personal life, I don't really worry about my data. I use the public systems. I use it mostly passively, and I accept every cookie. I love that the machine learning is tailoring what ads to send to me, that my Google feed is going to show me, pictures of dogs being adopted or the next period drama I might like because I enjoyed Downton Abbey. I enjoy that it's learning from my past use, and those algorithms are working really well to show me content that I want to see. In my professional life, it's completely different. I am much more protective of the data. I only use private AI systems. As you know, at BDO, we instead of ChatGPT, we have ChatBDO, an internal system, because I'm very, very conscious that the data that we use have to be protected. And there's always a fear that if you're using a public system, they can aggregate that information. It can gather information that can move the market, or aggregating a whole bunch of public information, they can reverse engineer into proprietary or confidential or even classified information. So in my private life, I use it more passively and for more fun things. And in my professional life, very, very guarded and protected of the data security.
All good points. Julie, bring out your clinician side, your physician side. Tell us how AI is being used in healthcare delivery and in the business behind healthcare.
Sure. Sure, we can go into more details in a bit, but I would lump it into two big buckets, or maybe three or two and a half buckets. First is patient care in terms of making a plan, a diagnosis, and a treatment. The second is revenue cycle management. That's the business behind healthcare, the front end scheduling, the prior authorization, submitting bills, appealing denials. And then the third or overlapping bucket is documentation, because documentation of the clinical encounter is important both in terms of delivering quality patient care, and then also making sure that providers get paid accurately and payers pay accurately in the revenue cycle management aspect.
Julie, AI has been around really for quite a long time. When you think about some of its early rudimentary uses in healthcare, what is AI already good at?
Sure, there are some things that AI is already super good at, possibly even better than an average clinician. AI is great at assimilating huge volumes of information quickly. So think of taking a voluminous medical record, reviewing that chart, instantaneously identifying all of the medications that patient is taking or being prescribed to take, and identifying drug-drug interactions and contraindications. Another thing AI is really good at is pattern recognition, and that can be applied for visual type patterns for radiology, reading an MRI, pathology, reading a tissue sample. The AI has been proven to be pretty accurate on that. And again, this is an enduring podcast, so when folks read it a year or listen to this a year or two from now, AI just keeps improving in that regard. One thing that I will note about AI is AI cannot replace physicians' medical judgment. It can be a tool to enhance medical judgment. And AMA, the American Medical Association, is trying to rebrand AI in a way. Instead of having AI stand for artificial intelligence, they're promoting that it should stand for augmented intelligence, to make the point that AI is a tool that human physicians use, not a tool that will replace human physicians. And we see that in other fields as well, trying to rebrand AI to make it friendlier, more accessible. I stopped reading the Washington Post, the paper version, and now I listen to it while I walk my dog. And just last week, this story is read by an AI generated voice. The AI started introducing themselves. Instead of one voice, now it's, "I'm Josh, the AI voice, and I'll be reading your story. I'm Chloe, the AI voice." And we see that in marketing in general, to make things seem more virtuous, less scary. Like I go to what I used to call Dunkin' Donuts in the morning, and now is rebranded as Dunkin'. Either way, I'm still getting a French cruller and a Boston cream, but I feel more virtuous about it going to Dunkin' or going to KFC instead of Kentucky Fried Chicken. So I think there is a movement to try and make AI seem a little bit more accessible and less frightening. And then one particular thing I want to talk about how some clinicians are using AI is an ambient listening technology, which basically how that works is you can turn on this ambient listening system when a physician, nurse, I apologize, I know physicians and nurses don't like being called providers, but sometimes I will say provider to try and be more inclusive of all types of healthcare professionals. So when providers are meeting with a patient, and the ambient listening can create a record of that encounter to um, be used for the medical record documentation, but it can also go beyond that and start working on differential diagnosis and treatment plan.
So I imagine that ambient listening, that can save a lot of time, can it?
Well, I would say maybe. And a lot of times we make the connection between electronic health records and AI, like if the past is prologue for electronic health records promise to save time and improve care. Well, how's that working? I mean, most physicians now say they spend more time on documentation, more time on paperwork, more time on record keeping than ever before. So I'm optimistic that someday the promise of time saving will occur, but but maybe quite not yet. But there are some other positives. I remember when we first rolled out electronic health records, the provider had to, pull out turn their back to the patient, pull out a keyboard, hunch over, and start typing. Before we had, the cart so that you could at least still maintain eye contact with your patient. So even if it doesn't save time, some potential might be that you can focus on talking to the patient, make eye contact with the patient because you're not turning your back to type at a monitor. But what is super important, though, is to remember that the physician, the provider, has full responsibility for what goes into the record and an obligation to review and verify what the ambient listening generated to make sure it's accurate, because that's not that's a non-delegable responsibility to ensure that the record that you sign and certify is accurate is. And then we worried about electronic health records with copy and paste and note bloat, that the records could balloon. You could see that potential happening with ambient listening as well. And then one other thing to think about with note bloat is that the provider is responsible for everything that's in the record. And I remember back when I was a medical student in the 1990s, we would, we had paper records, and sometimes the medical students would spend so long writing their history and physical that instead of writing it directly in the chart, you'd take the pages out, walk around on your with a clipboard, write the note, and then insert it later. And I had one attending physician who said, you know what? I'd rather you didn't put that in the record. Like, you can just write your extensive history and physical and just keep that for educational purposes, because you don't need a medical student history and physical. And his reasoning was that at the end of a note for a history and physical, you write your differential diagnosis. And you consider every possible diagnosis that the patient could have. And you start with the most likely, and then you work your way down to the real thing, real uncommon things, what in medicine we call zebras. And he had a malpractice case where he hadn't read the medical student note. Their number 9 on the differential diagnosis ended up being what the patient actually had. And he was held responsible for, well, why didn't you consider that condition? And he said, because it was really rare and it was presented, but your medical student considered it. And so you could see the same thing happening where the artificial intelligence creates a differential diagnosis that is so much more extensive than what a busy clinician would actually include. And then my last point on saving time, there's also the question of if you have to disclose that you're using it to the patient. So for true informed consent, that might take a little while to explain to certain patients exactly what the ambient listening is and get approval to do it.
Interesting point about seeing the forest for all of the trees with ambient listening and all of the additional data that is potentially being added. So, Julie, it does seem like the primary use cases and advancements for physicians, their use of AI are as a physician assistant. I described at the beginning, I use it like an assistant to help manage all the data that's available to them. So let's get into how AI can help with the administrative side of things, like revenue cycle management.
Sure. It might be a little bit more exciting and futuristic to talk about how AI can be used for a direct patient care, and that potential keeps growing. But for the here and now, I would say that the more immediate use is for administrative purposes, and it can be used on both sides by the payer who's processing claims, authorizing care, denying claims. We're seeing a lot more denials, and the healthcare providers, the hospitals, the physicians. And some estimates say that about half of providers right now are using AI in some way, maybe to help with appeals, maybe to help with documentation. But again, so important to realize that AI is just a tool, and you always need to keep a person involved and rely on the person's professional judgment. With the rise of managed care, utilization controls are even more important. We're seeing more prior authorization requirements. We're seeing payers increasingly using denials as a tool, maybe even using denials that will ultimately get overturned if the provider appeals. And I've seen some estimates that providers are spending about $20 billion a year now trying to overturn denial. So there's a huge opportunity to use AI to reduce administrative costs and maybe even get better outcomes.
So, do you see the potential for AI use on more on the provider side, the payer side, both?
Definitely both. And think back to one of my favorite movies from the 1980s, Real Genius, with a very young Val Kilmer. There's that classic scene at the university where the students have stopped coming to class because it's not worth their time. So the students have set up tape recorders on each of their desks, and the teaching assistant walks in, sets up the projector, hits play, and the professor's lecture is beamed out to the students to record. And I can see both sides using AI in a way like that, where the provider is using AI to submit the claim, and the payer is using AI to deny the claim, and then the provider is using AI to submit the claim, and neither is programmed to end the conversation. So the cycle to infinity, where the Washington Post just had a data article on how much energy AI uses, and apparently saying thank you to your AI, then they say you're welcome, and it measured that in terms of how many disposable bottles of water that's equivalent to. So we need to make sure that that the AI is set to at some point end the cycle.
Mm-hmm. We'll talk about the bright side of both the insurers and providers both using AI.
Sure. I would love to see AI used for real-time prior authorization approvals. I mean, reasonable people can disagree about what kind of administrative burden prior authorization entails and when it's appropriate and when it's not. But for a procedure that is requiring prior authorization, if we could do that in real time, that would help everyone. In medicine, patients, we call it lost to follow-up. When you recommend something, but the person has to come back at another time and it just doesn't happen for whatever reason. So think about the example of a medicine that needs to be injected. So there's many situations where, like an arthritis medicine or something, where the patient is there, the doctor's there, ready to do it, and they say, okay, can you just do it now? And the doctor says, no, we need to get prior authorization from your insurance company, which is a process that takes a couple weeks. The patient leaves, maybe they get approved, maybe they take another day off work to come back. If that could be done right away, you wouldn't lose the patient to follow up. It would cost less for the insurance company, and it would save that future appointment that the physician could give to a different patient. So it's win-win-win for that patient, the payer, the provider, and other patients who would have better access to care.
Okay, so Julie, talk about how it can help with staffing issues and administrative burden, how AI plays a role there.
Sure. Providers now say that they have more administrative burden than ever. There are staffing issues, tighter margins, more use of prior authorization, and it's not just managed care. Other more traditional types of insurance are also increasingly using prior authorization and increasing denials. So there's great potential to use AI to streamline. So on the provider side, you can use AI to proactively identify which services the insurers are targeting for denials, and then proactively ensure that the documentation is good and hits the buzzwords and the requirements before you submit. So when you submit the first time, as opposed to on the back end, and the AI can gather data from the chart that's needed to support the request, and of course not input it without oversight, gather the data, and then the provider would have to certify that that data is correct and accurate. And with machine learning, it can even tailor the request to what that particular payer requires and what that particular payer is focusing on. So maybe your staff can focus more on spending time with patients, and the AI can continue learning and keep getting better.
So tell us, though, about some of the vulnerabilities associated with using AI in that context.
Sure. Well, machine learning is only good as the inputs, as the data going in. So it's important to be careful who's programming the AI, and also to worry about bias, both intentional bias and unintentional bias. First, coming from the OIG perspective, we always said that if you make a system that's giving out money, especially government money, someone out there will figure out how to cheat that system. And industry players may be looking to increase sales. Now, in the not in the healthcare context, I don't know if you saw earlier this week, there was a lawsuit against Spotify that someone was messing with the algorithm to try and increase the sales for Drake, to suggest that people are listening to more Drake. So the stakes on that are pretty low, right? Who cares if the algorithm is going to give you more Drake? How about when the algorithm is going to give you more opioids? Now, if you recall, you and I, with our colleague Andrew Van Landingham, published an article in JAMA Internal Medicine back in 2020, where we discussed a case where the clinical decision support, the CDS, the clinical decision support in the electronic health record, was manipulated by a drug company that manufactured opioids. And it was manipulated in such a way to encourage physicians to prescribe more opioids, more of this particular kind, expanding the indication. So for more patients, higher doses more frequently. So the stakes are really high there if the algorithms are being influenced by someone with an agenda to push a particular kind of treatment.
Yes, clinical decision support's okay to remind someone about it being flu season, not so great to be, pushing.
Right.
Yes.
Right. Like what we used to call academic detailing versus commercial detailing, where you're promoting certain kinds of prescribing for proven good reasons versus certain kinds of prescribing for financial gain.
So Julie, tell us about unintentional bias in AI.
Sure. The machine learning depends on what's being fed in. So there's the organic, what cases it's seeing. And then there's also some efforts to train the AI on LinkedIn. All the time I get advertisements to see if I want to get paid to train, to review medical cases and train AIs. I think they pay you in Amazon gift cards or something. I've never tried it. A friend of mine does it, and he says it's kind of fun, but it reminds me of a job I had back in college. I grew up near where the Educational Testing Service, where ETS is. So if you remember taking your GRE on a computer, well, you're welcome. I was in the group that helped them transition from paper tests to a computerized version. But what's curious about that is, I thought it was the best job in the world. You got $50 a day and a catered lunch to show up and take practice tests. And who did they hire to do it? It was college students who happened to be on break somewhere near Princeton, New Jersey, and whose mother maybe saw the ad in the Princeton Packet or the Town Topic. And then lo and behold, you find out the test is biased. Of course it's biased when you trained it. Exactly. So I think about the transition to artificial intelligence a lot like the transition from paper to digital. And it's a tool with a lot of promise, but we have to be careful how we use it. And let me just give one important warning, just a real practical tip to folks listening who might be physicians or hospital administrators who are establishing AI tools for the medical records. Once you put information in the medical record, it's very hard to get that information out. And it's also important to remember that you need to set up your systems in a way that you're setting up your providers to succeed, not setting them up to fail. And we've seen with electronic health records, with the autofill and automatically creating a review of systems and carry forward, that we see documentation of things that didn't happen in the medical record. And you'll remember this from one of our OIG audits, where we had a patient who came to the emergency room unconscious and never regained consciousness. But the box was checked in the medical record that the provider had counseled that patient about smoking cessation. And now it's great to have your protocol be encouraging, no wrong door every time a patient touches the healthcare system to talk about smoking cessation. But when your system is set up, and that was probably an autofill, it required the provider to uncheck when they didn't do it. When you set it up that way, you're going to have false things in the medical record that the healthcare providers are responsible for. So AI is a powerful tool, but it must be used carefully.
We would be remiss to not talk about cybersecurity and AI in healthcare context.
Yes. Yes, the stakes are so high now. When we used to do cybersecurity audits, we'd set a van in the hospital parking lot and see if they could drop onto the system. We were only worried about gathering the data about privacy and hacking into the system to gather the data. But now with the Internet of Things and the robotic surgeries and the connected IV drips and the little robots that deliver the medicines. There are so many things beyond just gathering information, but hacking in and taking over and causing bad things to happen, that the stakes are much higher than listening to a little bit extra Drake.
Right. So you earlier talked about bias and AI equity. How can it be used to promote equity?
Thanks. I love that question because, from the OIG perspective,
you
we're
do.
highlighting
Yes.
vulnerabilities. And now I finally get a chance to have a little optimism and have some faith in the future for how some of these technologies will be used to promote equity. So I'll mention two. First of all, scheduling. One of the most important functions of the front end revenue cycle management is patient scheduling. You can't access care, except for the emergency room where you can walk in. You can't access care without getting an appointment. And we've talked about this. The bane of my existence is calling the pediatrician to get an appointment. You wait on hold. Sometimes their workflow is tell us what you need and then we'll call you back. Now, if you're working in a warehouse somewhere to find a private time to be on hold for 15 minutes and then a call back, it's hard to get an appointment. It is much more equitable if you can privately, on your own time, access the appointments electronically. The other is translation services. I remember as a student before the class standards, sometimes awful practice. You might ask a child who's with the patient to translate for you. AI has made translation so much easier. And then even for people who speak English, physicians, we often use words and language that's hard to understand. Some patients apparently turn to an AI summary to provide the plan in digestible, accessible language.
So, Julie, what are some key takeaways to mitigate risk?
I would say always keep a human in the loop. The augmented intelligence not replacing human intelligence. And then two risks that we should mention are hallucinations and sycophancy. Hallucination is when the AI makes things up. And in government, at the highest levels, people have fallen for that and included hallucinated citations in government reports. Sycophancy is a special type of sort of related to hallucination where it gives you more of what you want. It confirms what you're already saying. So sycophancy is great for those AI friends you see advertised. Sycophancy is super dangerous for an AI therapist, right? If you're asking the AI friend, should I go to a happy hour? Great for a sycophantic answer. If you're asking the AI therapist, should I harm myself? Incredibly dangerous. And then the next thing I'll mention is the importance of complying with laws. It's a dynamic field, and there are multiple authorities that apply, federal and state, the FDA regulating AI as a medical device, HIPAA for data privacy, even the Federal Trade Commission for deceptive claims and unfair practices. And then states might be having particular laws. On the cutting edge is California, Colorado, and Utah. But again, I would just say, keeping humans in the loop, humans are accountable, and maybe making some efforts to minimize bias. It's not enough to just be neutral, but making efforts to keep the technology improving and minimize the bias.
One more question, Dr. Tietzman. What are a few key questions to ask if you're thinking about adopting a particular AI function?
Sure. I would say the most basic question is, does it work? And then I would think about, do I have to disclose that I'm using it, and to whom? Do I tell the patients? Do I tell the payers? Can I bill for it? If I'm billing, how? And then are my data protected? And then finally, is the technology biased? Is it promoting equity? And how can we make it better?
Mhm.
And now, if you don't mind,
A
let
whole
me.
other podcast on just that. A lot to unpack in that in that. But yes, go ahead.
Yeah. And now, if I could ask you a few questions, let's turn to the government oversight
Hmm.
angle, and if you could talk a bit about how technology, including AI, is being used for government program oversight.
I'm really glad, Julie, that you phrased that very broadly, because in oversight right now, in contrast to what's happening in a clinical setting, we are oversight isn't sort of at that same point in terms of deployment. And so it isn't so much about the use of AI as it is about the broader use of technology and data in oversight. And so while AI is moving very, very fast in clinical environments, government is really still in the early stages of AI adoptions. And the most meaningful advancements have come from analytics platforms, systems that bring together data, tools, services, and people that do things like support investigative, audit, and monitoring oversight work, that generate leads by doing things like spotting trends in billing, in payments, or other types of like grant drawdowns that could indicate improper payments or some funny business that might be happening. So think of it more as early detection. When something looks off, the system is then flagging it for deeper review by a person. It really comes down to data helping humans decide where to look next. A good example, and one that's very, very current, I think, is of an analytics platform is the Pandemic Analytics Center of Excellence, or PACE. And that was developed during COVID, and it came out of the CARES Act. It brought together oversight professionals from across government, across different departments, auditors, investigators, data scientists, and it provided a shared environment for them to analyze data in near real time. And it let them link information, and that's the most important piece, honestly, across programs like the provider relief funds coming out of HHS, unemployment insurance out of labor, and small business loans coming out of SBA. And with that kind of platform and shared data, shared platform, you could see patterns that wouldn't have been visible within any single data set. You could see if somebody was applying for all of these different programs simultaneously, and really sort of have then a trigger to be able to kind of monitor what was going on there. And that was an enormous step forward in oversight capability. Truly shouldn't be overstated. I mean, it was very, very important. And analytics platforms like PACE really are a model for what's possible for when you combine the right data, the right technology, the right expertise. It can keep pace, pun intended, with fast-moving programs. And the next big way government oversight is using technology is through risk modeling. Some oversight organizations, including the HHS OIG, have built systems, and these have been in place for quite a long time, frankly, that don't just look backward at what went wrong, but try to estimate where the next vulnerabilities are likely to occur and how big those problems could be. When I was Inspector General, you know this, I consistently spoke about the importance of making data-driven decisions, how we used a wide range of data to zero in on the highest risk because we couldn't possibly audit or evaluate everything under the HHS umbrella. At times there was over $2 trillion in payments coming out of HHS and hundreds of programs. You couldn't audit, evaluate, investigate everything. And so certainly for the audit and in evaluations, risk models helped us target areas that sort of signaled risk and offered potentially the greatest potential for positive impact.
Do you mean like trying to anticipate what this season's flu strain will look like?
Exactly. I do think very much of it as the oversight version of population health. For both the analytics platform and for risk modeling, the value comes from connecting the data, not just collecting it, where you're bringing together those data points that are typically isolated to see if there's a pattern to maybe triangulate something. And in order to do that, you need data. And HHS OIG has just a lot of data, enrollment data, encounter data, prescription and laboratory data, and even enforcement and compliance data. And because of that richness, OIG can and does model what normal looks like across millions of providers and flag anomalies and outliers that might signal a problem. Signal a problem as in, you need to go behind that and verify whether there actually is one. But, to signal, detect things like rapid upcycles in billing, where a provider's claims volume suddenly spikes in ways that don't match patient volume, or unusually high billing for a service type in one geographic area that doesn't, seem to exist anywhere else. Or even when there are provider to beneficiary ratios that seem unrealistic to predict where there's a risk and a need for follow-up action. It's a clue if there are, if there is one hospice for, every 4 beneficiaries in in a county in California. That's a clue. You want to follow up on that. So data-driven risk modeling really does and did help inform oversight priorities in deciding where, that follow-up action may be needed, audits, evaluations, or inspections. And, really, anytime you're cracking the OIG work plan or, more like pulling it up on your website, whenever you see something in the public work plan, it is grounded in some sort of risk analysis, risk modeling.
Yeah, so it sounds like you can use the AI to identify the pattern, flag the anomaly, the deviation from the pattern, but then boots on the ground.
Right, right.
So what else is the technology making an oversight difference?
An area that I want to zero in on is automation in robotic procedures, because it doesn't really grab a lot of headlines, but healthcare oversight includes automating routine monitoring tasks, the kinds of things that used to require teams of people running manual checks daily, monthly, or some other regular basis. And some of this automation has been around for a long time. Things like automated edits. One example that listeners will be familiar with are rules that are built into claims processing systems that automatically flag or deny payments that don't meet policy parameters, duplicate claims, mismatched procedure and diagnoses codes, billing for deceased beneficiaries. Another area is in IT and cyber oversight. You talked about that from a risk perspective from a clinician side, but from a program oversight perspective, in IT and cyber, there is continuous vulnerability scanning of program systems to detect new weaknesses or configuration changes that expose the system to risk. Like that is an ongoing process that happens. And then, looking at compliance monitoring, continuous scanning to identify where there might be compliance risk. And I'll give a hypothetical example of when this could happen, although some of this is more idea than what's potentially in practice right now. So when OIG resolves a fraud or kickback case with a healthcare entity, it sometimes offers what's called a corporate integrity agreement, or CIA. And that is essentially a deal. The company stays eligible to bill Medicare and Medicaid by avoiding exclusion from federal healthcare programs, but it agrees to strict compliance monitoring, independent reviews, board accountability, training, and reporting to OIG. But every so often, a company refuses to participate in a CIA, and OIG publicly deems this healthcare entity high risk and commits to enhanced scrutiny for that healthcare entity. And this is where automation could really make a difference. Imagine a set of robotic tools that quietly keep tabs on that high-risk company without having a team have to do it manually. For instance, it could be monitoring claims and enrollment. Bots could be automatically flagging new billing activity from any newly registered affiliate under common ownership. It could be doing corporate link analysis where algorithms are cross-referencing business registrations and NPI ownership data to see if the company reappears under a different name or a tax ID. It could even be, looking across public records. Automated searches could watch for new enforcement actions, bankruptcy filings, or mergers involving that company. In theory, all of that could be happening passively, and the same type of automation could even involve alerting OIG if there is a pattern shift. A lot of potential there.
Now, talk a little more about the AI. From a healthcare oversight perspective, how much AI do you think is really in use?
That's a great question, and one that I get a lot. And the honest answer is that AI in government oversight is growing but it's uneven. Most of what's in use would still fall under the umbrella of what I just talked about, advanced analytics or automation, rather than what we'd consider true AI. But having said that, there are, some real signals of change. For example, the One Big Beautiful Act specifically directs HHS to invest in AI tools aimed at reducing and recovering improper payments. And that's a big statement. Congress is saying we expect technology to help us be better stewards of taxpayer funds. And CMS, the Centers for Medicare and Medicaid Services, announced that it will use machine learning for its risk adjustment data validation audits, its RADV audits for Medicare Advantage, essentially using AI to help determine whether diagnoses that drive payment are actually supported by the medical record. And that is truly a significant application of AI inside the sort of regulatory audit process.
Now, when you were the HHS Inspector General, what were some of the considerations or questions you had about AI use in program oversight?
Certainly, starting with the enormous potential for the use of AI, looking at it, just from the fraud angle alone. And I think this is where the most potential exists. Agencies like HHS OIG have decades of enforcement data that can be used to teach algorithms what red flags look like. And because that information spans providers, geographies, program types, it's a really rich source for AI deployment. But I thought about, how oversight had to walk before, it could run. And when I was IG, the conversation always kept at the fore the purpose, of what we were, looking to do and transparency around it, not just whether AI could flag something, but why it did, thinking about some of those inherent biases that you were talking about earlier. Also, whether we could explain the reasoning, could we validate the output? Critically important, were the underlying data complete, accurate, timely? If you look at, OIG reports, probably 5-10 years ago, huge focus was just simply looking at whether the data were there in areas like Medicare Advantage. And so I thought those questions, which are really seemingly simple questions, were essential to maintaining fairness and public trust, and it is the most responsible thing to do. And of course, you've talked about this so much, that human element and how oversight work really does depend on professional judgment always. And that's not, specific to use of automation and risk modeling and AI. There does always have to be professional judgment. When a pattern is identified, we still need to test it, to contextualize it, and decide whether, there's actually a fire behind that smoke. And it's no different for AI. Those things still need to be, the human element still needs to be there. And I realize much of what I'm describing is a governance framework, and that will be, I think, an ongoing process, an iterative process for oversight entities as they deploy AI.
And what can you tell us about OIG's current work plan?
Mm-hmm.
Is OIG zeroing in on the use of AI specifically yet?
AI specifically, not much, and that's telling. If you look at their plan, you won't see many projects focused on AI, and that makes perfect sense to me because the rules around AI, how it can or should be used in Medicare and Medicaid, just really don't exist yet. As far as I know, there aren't formal and broadly applied standards that define, what constitutes a clinically valid algorithm in a coverage payment or prior authorization context. Are you aware of any, formal standards? I'm not. And any OIG, needs to have a law, a rule, guidance with which it can compare something against. And when that doesn't exist, you're really sort of at the point where you're maybe describing things, doing descriptive work, and without sort of documentation specific to things like algorithmic decision making, that says how a payer or provider should record the use of AI when making or justifying a decision, you're really kind of, oversight needs to take that into account. And we don't yet have guardrails on the fundamentals. And until those things exist or are better defined, oversight is more in a sort of gray space. And so out of OIG, I would expect maybe as they're collecting data, maybe for them to be asking if AI was sort of used in clinical settings and how, and to show how that algorithm, to explain that algorithm. I wouldn't expect it to be, for them to come out with improper payments because AI is used, because those rules just aren't really there yet.
Very interesting. And could you close us out with maybe 3 key takeaways for healthcare entities?
Healthcare entities build governance before you need it. Even though regulations on AI and advanced analytics are still forming, that governance shouldn't wait. Organizations that already document how they design, test, validate, and monitor AI will really be ahead of the game when that oversight catches up. Second, transparency builds trust. Program administrators and oversight entities will be asking you to show your work. And whether it's AI-assisted documents, building automation, or predictive analytics, to anticipate those questions about how those tools reach the conclusions and actions that were taken. And then, it can't be said enough, right? Dr. Tietzman, oversight needs to keep people in the loop. So keep people in the loop.
That is terrific advice. Thank you for sharing those words of wisdom, Inspector General Grimm.
And thank you, Dr. Tietzman. This was a delightful conversation.
And thank you all for listening through to the end. And thank you, BDO and AHLA, for making this podcast possible.